All right, greetings everyone. In this video, we'll explore conduction system anomalies on the EKG. Namely, we'll look at what bundle branch block does to the appearance of the EKG. We'll take a look at how fascicle blockage appears on the EKG. And last but not least, we'll look at the pre-excitation problems that occur on the EKG and all of the associated changes. All right, so first and foremost, let's take a look at bundle branch block interpretation rules. So these, I don't know why people get hung up on this stuff, but they're really pretty easy. So let's take a look. We're going to take a look at right and left bundle branch block. So let's do left bundle branch block here. These are the rules, and right bundle branch block over here. All right, common to both bundle branch blocks is the fact that the QRS must exceed 120 milliseconds in duration. So if you think about this, this is going to make a lot of sense here. Remember that the bundle branches originate, they bifurcate off the bundle of His, and the bundle of His resides in the interventricular septum. So your money lead here for the initial determination of bundle branch block is going to be lead V1, and the reason for that is lead V1 looks at the interventricular septum. So in lead V1, the very first thing you want to do is you want to determine if the QRS complex exceeds 120 milliseconds. So both of these will have exactly the same parameter here. They have to have a wide QRS. All right, so the next thing we want to do is we want to look at the terminal wave of the QRS complex to determine if it's a right or left bundle branch. What I mean by that is when we look at the QRS complex, it can look one of two ways. It can either look like the one on the left that I've just drawn, or it can look something like this. All right, so let's explore the differences here for just a moment. If you look at this guy here, you'll notice that the last wave, the terminal portion of the QRS complex, is this guy. And this is a negatively oriented complex, which is known as an S wave. Compare that to this QRS tracing, and what you'll notice here is that the terminal portion, the last wave of the QRS here, is an R wave. So this is really important. In fact, the overall determination, the naming of this QRS complex is actually an RSR or an RSR prime, such that this is an R wave followed by an S wave followed by another R wave. We just say it's an RSR. You can say RSR prime as well. So when we're looking at bundle branch block possibility on the EKG, the first thing you do is determine in lead V1, is the QRS complex greater than 120 milliseconds? The next thing we want to do is look at the terminal wave of the QRS complex. If the terminal wave of the QRS complex is an S wave, you have left bundle branch block. If the terminal wave on the QRS complex is an R wave, then you have right bundle branch block. So think R for R, right bundle branch block has a terminal R wave. Again, this is in lead V1. All right, so the next thing we have to look at here for left bundle branch block specifically, in addition to a QRS that's greater than 120 milliseconds and a terminal S wave in the QRS complex, we also want to look for this pattern of inappropriate discordance. And I'll explain what that means. So normally when we have a QRS complex, it is typically followed by a T wave, and both of these complexes are oriented in the same direction. As you'll see in this case, the QRS complex is upright, and it is followed by a T wave that is also upright. So inappropriate discordance would be if you had a normal QRS complex and it was followed by a T wave whose force opposed the direction of the QRS complex, meaning that the QRS is upright, the T wave is negative, or it could be vice versa. You could have a negatively oriented QRS and an upright T. This would be a pattern of inappropriate discordance. The QRS and the T wave do not agree on which direction they should be traveling in. Well, this is kind of an important concept because actually in bundle branch block, we have a concept of appropriate discordance. That is to say, in bundle branch block, something that you'll find is that the QRS and the T wave will oppose forces, and that's a normal thing. That's an appropriate discordant pattern. And you'll find this pattern of discordance in leads 1 AVL, V5, and V6. All right, so left bundle branch block. QRS is wide, terminal S wave, appropriate discordance. You'll find that the QRS in leads 1, AVL, V5, V6, they look just like this. You'll have an upright QRS and a negatively deflected T wave. And in lead V1, you'll have something that looks like this. Again, appropriate discordance, QRS will be negatively oriented, T wave will be upright. All right, so in right bundle branch block, we're going to look at it a little bit differently. We're going to find a wide QRS, a terminal R wave, and really what we're looking for is an RSR pattern, just like the one I've drawn here. And we're also going to find that the S wave is going to be slurred in the lateral leads. So these are leads 1, AVL, V5, and 6. We're going to find this slurred S wave. And I'm going to show you some examples of that so that we can actually bring these rules together. All right, let's take a look at these different processes. All right, so let's take a look at right bundle branch block first. All right, remember, if we want to determine if there is bundle branch block at all, the first thing we want to do is we want to go to lead V1. Here's lead V1. And we want to determine if this QRS complex is wide. And indeed, this QRS complex is almost 4 small boxes. Let's just call it greater than 120 milliseconds. All right, if you want to put an exact number on it, it's probably about 140-ish. All right, so what you'll notice here is if we look at one of these QRS complexes, the last wave of this QRS complex is actually this wave right here, and this wave right here represents an R wave. So we have a wide QRS, it ends in an R wave, we already know we have right bundle branch block. Now we're going to look at leads 1, we're going to look at AVL, we're going to look at V5, and we're going to look at V6. And I told you the other thing we needed to look at for right bundle branch block was whether or not we have a slurred S wave. And you'll notice that this S wave here, it doesn't return to baseline very quickly like we would normally expect it. It slurs off a little bit here, and we don't want that. So this slurred S wave is, again, indicative of right bundle branch block. All right, let's take a look at another pattern here. So this is what left bundle branch block looks like. And you'll notice here, if we go to lead V1, we want to determine first and foremost, is the QRS wide? In fact, here it's probably close to 200 milliseconds. Let's call it 180 milliseconds, so it's very wide. And in addition to that, now we're going to go to lead V1, and we're going to determine what is the terminal wave of the QRS complex. In this case, it's this ginormous thing here. This is an S wave. So terminal S plus wide QRS in lead V1 tells us about left bundle branch block. Now let's look at some other components here. We're going to go to lead 1, we're going to go to lead AVL, we're going to go to lead V5, I should have picked this guy here, V5 and V6, and we're going to look for Q waves, and you'll notice there are absolutely no Qs here, so that's good. The other thing we want to look for is the pattern of appropriate discordance. In other words, do the QRS complexes and the T waves forces oppose one another? And in fact, if you look at this, they do in each and every single one of those leads. They oppose. So we have upright QRSs, we have negatively oriented T waves. This is called appropriate discordance in left bundle branch block. All right, so this is the pattern of left bundle branch block. All right, let's take a look at one more component here. The left bundle branch is responsible for depolarizing the entire mass of the left ventricle, which is just huge. And as a result, the left bundle branch block itself bifurcates into 2 separate components. The left anterior Hemi block, the left anterior fascicle, and the left posterior fascicle. And therefore, just as though we can have blockage of the entire bundle branch, in this case, we can also block just part of one of those fascicles, either the anterior or the posterior fascicle. So I'm not going to mention anything about left posterior fascicle block or left posterior Hemi block because it's truly a diagnosis of exclusion, and so we don't really need, it's very, very rare. We don't need to explore that very much in this video. What we do want to talk about is something that we see with some regularity, and that's left anterior Hemi block. And as with all of these other rules, all of these other conditions. There are just a small set of rules that we have to look for on the EKG in order for us to make this interpretation of left anterior hemiblock. So here are the rules. You're going to go to leads 2, 3, and AVF. All right, these are the inferior leads, and you're going to look for a small R and a big S wave. Then you're going to go to leads 1 and AVL, and here you're going to look for a big R wave and a little S wave. All right, so when we have this pattern in 2, 3, and AVF, little R, big S, and in leads 1 and AVL, a big R and a little S, this defines left anterior hemiblock. So let's take a look. Here are leads 2, 3, and AVF. In fact, if we look here, we have a small R wave followed by a deep S wave. So, yep, we have little R's and big S's in leads 2, 3, and AVF. Now we're going to do the same thing. Let's take a look at lead 1 and AVL. Here we have a big R wave followed by a small S. Here we have a big R wave followed by a small S. So this tracing is the textbook classic presentation of left anterior hemiblock. The next thing we want to talk about is accessory pathway presentation on the EKG. And so accessory pathways describe a condition that exists where there is a piece of tissue that is allowing conduction of electricity to take place somewhere between the atrial tissue and the ventricular tissue outside of the AV node. And that's never a normal thing. As you remember, the AV node is the gatekeeper. It acts to isolate atrial impulses, atrial electrical stimulation. It allows it to delay that transmission so that the ventricles can completely fill with blood. And then once that time delay has been accomplished, then it releases the electrical impulse and then the ventricles depolarize. So when we have accessory pathways present, that speaks to a pathway that exists between atrial tissue and ventricular tissue that is ungated, if you will. There is no gatekeeping mechanism there. It's an open access point such that anytime a stimulus arrives here, it will conduct down to the ventricular tissue with absolutely no gatekeeping or regulatory mechanism in place, which is unlike that of the AV node. So let's explore this for just a second. I want you to think of the SA node and electrical stimulation as being an outward concentric circle process, so that when the SA node depolarizes, when something happens here and it initiates the depolarization process, that wave of electrical depolarization starts to move outward until it stops for whatever reason. It could hit another piece of tissue, whatever it is, that is going to continue to move outwardly until there's nothing else to transmit through. So anything that comes into contact with this wave is either going to depolarize, or if it doesn't have the ability to depolarize, it's just going to ignore the fact that it received that message. And then ultimately, at some point, the AV node receives that message, and it decides to hang on to that message because of its inherent refractoriness to these stimuli. So the AV node is the gatekeeper here. So now take into consideration that we have this additional accessory pathway, and there's an accessory pathway that is essentially wide open, and that wide open piece here allows us to take and to transmit electrical impulses from the atrial tissue straight down to the ventricular tissue. So when this wave arrives here, it continues down this accessory pathway. This is ventricular tissue, and it pre-excites, meaning that it starts to depolarize this portion of ventricular tissue well before it was supposed to, because the AV node at this moment is still hanging on to the electrical impulse that it received. So think about the AV node on the EKG is represented, the delay in the AV node is represented by the PR segment. So if you want to think about the PR segment as occurring about 120 milliseconds, somewhere between 80 and 120 milliseconds, that delay is not appreciated when we have an accessory pathway. So the ventricles are allowed to depolarize. This little section right where the accessory pathway is allowed to depolarize somewhere between 80, 100 milliseconds prior to the rest of the ventricular tissue, and that causes an early departure from the baseline. So this is what it looks like. Normal QRS, you get a P wave, so this waveform is coming down here, and P wave depolarizes, causes a P wave on the SA node depolarizes, and it causes a P wave to show up on the EKG. This waveform depolarizes the tissue and eventually gets to the AV node. And when it gets to the AV node, you get this flat line, the PR segment following the P wave, and that represents the delay mechanism inside the AV node. And then the AV node, once it's had enough, it releases it down to the ventricles, and you get a QRS complex that follows. So this is normal mechanism. Now, when you have an accessory pathway, what happens is you still get depolarization of atrial tissue, meaning the SA node depolarizes, and it starts to send out this huge wave of depolarization stimulus. But instead of being delayed at the level of the AV node, once it gets to the accessory pathway, it immediately transmits down to the ventricle. So what happens is you end up getting a little bit of a reduction in the PR segment. And the reason for that is because you get less of a delay in the AV node and a faster response by the ventricles. So you get an early departure from the PR segment, and you get this wave that starts to happen, and that wave that starts to happen indicates depolarization of the ventricular tissue right around the accessory pathway. Now, once we delay 80 milliseconds, 60 milliseconds, whatever it takes for the AV node to then send this message down, once the AV node does transmit the message, the depolarization wave that's created through the accessory pathway eventually meets up with the depolarization wave that transmitted through the normal conduction system. And where that takes place, you get a little bit of a change in the way the QRS complex looks, and the QRS complex finishes off, and it resumes its normal appearance. So, presence of an accessory pathway on the EKG, namely a bundle of Kent, causes a few things to appear. The first thing to happen is you get a short PR interval. And the reason for a short PR interval is you have an early departure of the QRS complex from baseline because of the early or pre-excitation of the ventricular tissue that surrounds the accessory pathway. So that's the first thing that happens. Second thing that happens is that the QRS begins to widen. So this should make sense. As you lose PR interval, you got to give it somewhere, so you give it to the QRS complex. So you'll see the QRS is short here, and the PR segment is short here, and the QRS complex has widened as a result. The third thing that appears on the EKG is known as a delta wave, and the delta wave is this guy here. It is the wave that indicates early depolarization of ventricular tissue near the location of the accessory pathway. It's an early departure from baseline, and it tends to have a little bit of a less acute angle of departure than the QRS normally does. So let's take a look at all this. The best way to figure all these things out is not just to dumbly memorize the rules, but to apply those rules. So let's take a look at this EKG. So in this EKG, this is a pretty textbook EKG because you can see delta waves in a good bit of the leads here. And it doesn't matter which leads you go to. I'm probably just going to pick some out where the delta waves jump out at me, but you can really start anywhere. In fact, just like you can localize areas of ischemia on the myocardium using the 12-lead EKG, you can also localize the area of accessory pathway using the 12-lead EKG. That's beyond the scope of practice. Beyond the scope of this lecture, but we'll explore that in another video. So I just want to draw your attention here, for example, to lead V5, and I want you to appreciate that what's happened here is we get this delta wave, and then it resumes normal QRS here. All right, and you'll find that pretty much in every single lead here. This one's a pretty subtle departure. This one's pretty subtle also. This one's not. That's pretty obvious. And delta waves can also be negatively oriented. So here's one that's negatively oriented for you. And delta wave all over here. So what you'll notice here is that the PR segment has shortened not a tremendous amount in this tracing. It's about 2.5 little boxes. So it's not super short. So we have a short PR. In addition to that, we have delta wave. And in addition to that, we have a QRS that has become a little bit wider, and you'll notice that here it's about 120 milliseconds. So the presence of short PR, wide QRS, and delta wave, this guy here, that defines and describes an accessory pathway or pre-excitation. Specifically, we're going to eventually call this Wolff-Parkinson-White syndrome. That's the big accessory pathway name. All right, stay tuned for more.